Hey Jesse, how are you doing?
I'm good, how are you?
Good.
So it's on her. I'm trying to activate it.
Okay.
Services.
Okay, great. Unfortunately, most of the house staff are away.
Is it
Ski days.
Yeah.
Where you're going?
Yeah. Get to try it out on a smaller crowd.
Has the IT guy been around?
No.
Your talk is up though.
Yeah. I got it. Such as it is. I don't know if it's possible to do presenter view. That's the only thing that I would do differently.
To which, sorry?
To do presenter view. I don't know. There's no clock here to watch my time, right?
Will you? Oh, you haven't.
I've tried. It's going to be close. Yeah.
So, yeah, we'll see. Kind of. Maybe even talk about 12 people.
Yeah.
She looked into depression.
You know what? She fell through the cracks. Somehow, you know how when they come to team, sort of team thing.
How's it going?
Yeah, how are you?
For some reason.
So how much diabetes are you doing? Are you doing like a clinic or something? Or
No. I do hypertension clinic here, and I do obesity clinic in Carrigsdale.
Okay.
And so when I'm managing hypertension, I'll manage the diabetes as well.
No, it wasn't.
And so, but if somebody has diabetes and complicated diabetes, then I'm happy for them to stay connected with the diabetes clinic. Sometimes you go to one clinic.
Yeah,
diabetes,
to me it doesn't matter.
Yeah, I just leave it up to the patient that's often asked, do you want to continue forward with milk or diabetes? Do you want to stay here? And some of them say, they like to have both, and some of them say they just want the one. Yeah.
So you're billing under hypertension and obesity codes. Or you're billing the complex.
So yeah, exactly. So build a complex code, so it'll have hypertension, diabetes. Yeah, it should be okay because it's still. I don't have to be managing the issue to build, but just what I'm managing.
Or theory time.
Yeah, that's right.
You're all good with your
Do you know
presentation?
if it's possible to do presenter mode?
No, not without a laptop.
Okay. Yeah, and there's no Mac adapter for the laptop, is there? Here.
Do you have a laptop?
I have a Mac. I don't have the adapter piece that I.
Possibly, yes. I'm
might have one.
It's okay. I'll be getting started soon.
Okay,
Anyways, not to worry.
All right.
Yeah. That's okay. That's okay. Not to worry. I've got a clock right there.
Okay, good. Give it 1 minute.
Yeah. Have to have a little.
Switch back to smoker.
Yeah.
Unlike yourself, I do hear. Welcome to Grand Rounds, a small but select audience. And for that, I'm sorry, but can't apologize that we'll benefit from this Grand Rounds where others won't. It's a pleasure to introduce Dr. Jesse Bittman today, a new member to our Division of General Internal Medicine. And you can see the topics about obesity. I think we'll all be interested in this. It's a common problem. I'm proud to present Dr. Bittman to talk to us. Jesse.
So first of all, thank you everyone for coming out today, even without house staff covering the wards. Hopefully you guys can stick around for my talk. So I've been practicing in obesity for the last about not that long. It was never part of my plan, but I kind of fell into it when I did a rotation with Dr. Zentner and became passionate about the topic. So I'm hoping to share some of that passion with you guys. I also wanted to make a note that Dr. Capilouto gave a talk on obesity earlier this month. There's going to be a little bit of overlap with that talk, but I hope to have a little bit of a different spin. She talked a lot about the systemic approach in bariatric surgery. I don't cover bariatric surgery here, but I'm going to talk about things that we can all do to improve our practice in obesity. I have no disclosures, no financial conflicts of interest. I do practice in an obesity clinic at a hypertension clinic. And I'd just like to start off with acknowledging Dr. Zentner again for her help preparing the slides. Some of the slides were taken from her, so you may see a little bit of overlap if you've been to one of her talks. And then also just a mention to my patients from whom I learn every day about obesity. Objectives for today are to review the importance of treating obesity as a disease, including understanding the physiologic underpinning of obesity as a disease, understanding the implications of that for our patients, and then reviewing and understanding some evidence-based strategies for how we might manage obesity better. As well, I should mention, with this smaller group, feel free to interrupt if there's questions along the way. We can take advantage of the smaller group here. So I'll jump right in with a few numbers. You'll see different numbers, but essentially 60% of Canadians are overweight or obese. This Stats Canada report suggested that the levels are actually relatively steady over the last 10 years. You'll see a little bit of variation in that, maybe a little bit of increase. Not like America, where the numbers are skyrocketing. A little bit more stability in Canada. BC, a little bit lower rates of obesity than the rest of the country. Unfortunately, when you combine the overweight and obese population, that number really evens out across the country. So we're not as much further ahead than we might like to think we are. So we'll jump right into why it matters. And I'm not going to sit here and talk to you guys about the cardiovascular implications of obesity and the increased rates of hypertension, because we know that. We know about the increasing mortality as our BMI increases above 25. We know that it affects the whole body. We know that, we see that every day when we practice medicine. We see the implications of obesity for our patients. But one thing that I do want to highlight is something that we don't always think about as much, which is the psychologic impact of weight. That burden that people are carrying around with them beyond the physical weight. Higher rates of depression among our patients with obesity, higher rates of anxiety. Weight loss is associated with improved depression scores and overall mental health. There is a remaining question of whether that is, which direction that goes in. Probably depression is associated with weight gain. Certainly antidepressants, antipsychotics are associated with weight gain. But it likely goes the other way as well, where patients with obesity tend to be more socially withdrawn and have higher rates of depression. With that in mind, I wanted to focus a little bit on why it matters to our patients. And this is something that I ask all of my patients when they come in to see me. Why are you here? What's your motivation? Why do you want to lose weight? And I get a range of answers. Health reasons, definitely part of it. Often that's just a perfunctory statement. I want to be healthier. And then they move into the real reasons. They want to be more mobile. They have kids and they can't keep up with their kids. Appearance is a big one. I had a patient recently who said he's recently gained weight. He looks at himself in the mirror and he doesn't see himself anymore. That's not who he is. That's not how he wants the world to see him. Mood is another common reason. Interestingly, when they did a study of patients going for knee surgery who were recommended to lose weight, appearance was still the most common reason why they wanted to lose weight, not their knee symptoms. And amongst adolescents, bullying is a big concern. Nearly 30% of adolescent girls and 25% of boys said that bullying was their primary reason for wanting to lose weight. It matters to our patients. Our patients also note that they're facing bias in their healthcare. The bullying extends beyond adolescence, extends beyond the playground into healthcare. 53% of women noted that they received inappropriate comments from physicians regarding their weight. Physicians were noted as the second most common source of obesity bias, and it's from all healthcare providers. And it's not simply a matter of perception. Sometimes we may think this is how patients feel. We're not really, people are sensitive or overly sensitive. 40% of physicians reported negative reaction towards patients with obesity. Over 50% regard to patients with obesity as awkward, unattractive, ugly, and non-compliant. That's why I wanted to start with that first bold slide about assessing our own interactions, our own beliefs. Primary care physicians spend less time with patients with obesity. And unfortunately, obesity specialists are not immune to this. We have the same rates of implicit bias. And in fact, in preparing for this test, I took an implicit bias test and was surprised and disappointed in the results of that. And this is impacting the healthcare of our patients, the health of our patients. Our patients with obesity are delaying healthcare. They're avoiding screening. Visits. Women are avoiding their cancer screening visits due to concerns about how they're going to be perceived, due to comments that they're going to get. When patients receive negative comments, when patients perceive a negative interaction, they're less likely to engage in healthy behaviors. They report eating in response to those feelings, feeling like it's hopeless and not engaging in their healthy behaviors. So how we present ourselves, how we discuss with our patients is having an impact on them. It's having an impact on their healthcare. And we know that there's benefits. We know that there's benefits to weight loss. The key in this slide is that I want to focus on two numbers, 5% and 10%. That's where we start seeing benefit of weight loss. In terms of diabetes prevention, in terms of blood pressure lowering, in terms of A1C improvement, in terms of fatty liver, that 5%, that 10%, those are the key numbers. 10% weight loss, body weight loss, is considered a success in the obesity world. That may not be considered a success to our patients, and that's something we need to consider is what are our patients' expectations, managing our patients' expectations from the outset, and recognizing that that weight loss is important. It also brings up an important point that sometimes we'll see patients and they'll have obesity, and we'll not ask them what their weight was before. And sometimes patients will come to us and they'll have already lost a significant amount of weight. They'll still be overweight, they'll still have obesity, but they've already had such a big improvement, and we need to recognize that. We need to recognize that what patients are doing for themselves before they come see us. I do just want to move on to a little comment on the pathophysiology of weight, because it'll come back up further in the talk. I think Dr. Capilouto went into this in a little more detail. She's certainly more of an expert on this than I am, so I'm going to keep it a little bit superficial. But essentially, the brain regulates our eating. There's two main pathways there. There's the hypothalamic hunger system that regulates that we need food. That's why we're getting out of the cave. We're going and hunting down on the savannah. That's what's kind of driving our hunger. But there's also the mesolimbic reward pathway. That's our emotional eating. That's our desire to eat a piece of cake after our Thanksgiving meal. That's our desire to eat when we're sad, eat when we're stressed, eat when we're tired. That's the mesolimbic reward pathway, giving us that little spike of dopamine, that similar to our opioid, involved in our opioid reward pathway as well, and that will come up again later. The hypothalamus is regulated largely in the arcuate nucleus. The two main sources of regulation are the agouti system and the POMC. Agouti, for those of us who speak French, can remember goûter, eat, taste. POMC, that's our fullness, our satiety hormone, our satiety neurotransmitter, our satiety system. That's interacted on by peripheral hormones as well. This is just a selected selection of hormones. There's many more that are interacting. From the gut, we have ghrelin increasing our hunger. We have other hormones, PYY, PP, CCK, and GLP-1 that are signaling the POMC pathway to signal satiety. Those will come up again later as well. That's why I mentioned them. From the adipose tissue, we have leptin being secreted. Leptin levels increase. Leptin is a satiety hormone released by fat cells. Leptin levels, again, decrease our food intake. It's been shown that people with obesity, in fact, have normal levels. Most people with obesity have normal levels or high levels of leptin. There are some people who are leptin deficient. Those people who are leptin deficient respond to leptin infusions and decreasing hunger. Most of our patients with obesity do not. When leptin's given, there's no change, and there's thought that there's a leptin resistance, a central leptin resistance, why they're not responding. GLP-1, I'll talk more about, of course, when we get to treatment. So here we come on to treatment. And just go on a diet. When I started practicing obesity, all my colleagues, many of my friends, and all of my patients every day ask me, what diet should I go on? Can't I do this with diet? What's the best diet out there? There's a pervasive theory out there, calories in, keep them less than calories out, move a little more, eat a little less, use some willpower. What could be easier than that? Unfortunately, not that easy. I'll come back to that. In terms of what diet I recommend to people and what diet's best. Realistically, there have been a number of studies comparing low carbohydrate versus low fat diet. It's not a big difference. This study here from 2009, out at 6 months, there was no significant difference between dietary composition. Granted, the low carbohydrate wasn't necessarily what we would consider a very low carbohydrate diet at this point, but there was no significant difference, about 6 kilograms weight lost in all groups, and out to 24 months, still no group did any better than the other. All had significant weight regained by 24 months. Looking at it a different way, looking at it from named diets, we see that out at 6 months, maybe a little bit of a difference, Atkins having the most significant weight loss. By 12 months, Atkins is no longer the best. Low-fat diet, a little bit better, not significantly, of course. And when they group them into macronutrient composition, there's really no big difference between the low-carbohydrate and low-fat diet. And that's what I tell patients. It doesn't really matter. Cutting back a little bit is going to help, but it's not necessarily going to get you there. And here's why our dieting is not really effective. Our body doesn't want to starve. We're adapted to hold on to weight, to hold on to fat for those starvation periods. That is a physiologic adaptive situation to our evolution, to many thousands of years where we were out in the savannah facing famine. We would hold on to fat. Our body's designed to do that. When we lose weight, our ghrelin levels increase. And even out at a year, they stay increased. Even in response to food, they never drop down to the same levels that they were. Our peptide YY, our amylin, our CCK levels drop. Those are satiety hormones. They drop, the levels drop, and they stay down out to a year. So our body's fighting us. We've lost weight, we've done all this hard work, and we've gone into starvation mode, and our body's fighting it. Our whole body is telling us we need to eat more. Not on here is our leptin levels. Leptin released from our fat cells. Our fat cell, when our adipocytes shrink, they release less leptin. We feel more hungry. So our body's fighting this. And it's the same way in hypertension. When I start one antihypertensive, the other counter-regulatory pathways increase. Our bodies want homeostasis. They don't want to allow us to lose weight. Coming back to the diet for a minute, looking a little more closely, I'm about 5 to 8 kilograms of weight loss across the various studies. If we look in a little more detail at that first study that I mentioned, baseline body weight, 93 kilograms, BMI 33, average weight loss at 6 months, 6 kilograms, 6.5%. That's right into that. That's right in that 5 to 10% that we were looking for. Great. New BMI 31.2. Still obese. Still would qualify for obesity, but significant weight loss. When we pull it out to 2 years, the weight loss is now 4 kilograms. We're below that 5% weight loss, and we're starting to not see the same benefits, with a 50% of the weight lost regained. So, in terms of diet, absolutely it's important, but treating something with only diet is like when a patient comes to me with a blood pressure of a 200 over 120 and I give them a DASH diet and tell them to go away. When a patient comes to me with an LDL of 5 and I tell them, go for a profile diet. That'll be fine. That's all you need. Eat less saturated fat. I would never do it. I would be worried about being sued if I did it. And if that's what a patient wanted, if a patient came in with a blood pressure of 200 and said, can't I try diet first? I would in fact argue against that. I would strongly argue that that was not a safe thing to do. So why is it that this day and age, I'm still doing that with obesity? I have patients with a severe metabolic disease, with an increasingly understood underlying hormonal and neurophysiologic pathophysiology, with effective treatments, and I'm still saying, just move more. Just eat a little less and you'll be fine. Just white knuckle it. Just smile more for your depression. Just smile it away, laugh, cheer up, don't worry about it, relax and your blood pressure will come down. I don't do it because I have medication, so I don't need to. So we come into the 3 medications available in Canada. First is Orlistat, been around for many years. Selective lipase inhibitor, binds fat in the duodenum, decreasing our amount of calories that we absorb. Significant weight loss with this. Of note, this is in the people who completed the trial. So, and with very high rates of dropout, very high rates of adverse effects, not a medication that I consider useful for weight loss. And part of that is it doesn't do anything to affect that hormonal neurobiologic basis of obesity. People go into starvation mode on it, and their hunger increases. We haven't really treated the underlying aspect. And if it was only a willpower issue, you're eating the wrong foods, maybe this would work. But it doesn't. But it just doesn't work. So let's move on to things that do work. Let's start with liraglutide. Most of us are comfortable or have some comfort level with liraglutide in the form of Victoza for diabetes, labeled as Saxenda up to 3 milligrams for weight loss for obesity. GLP-1 agonist has action in multiple places in the body, released normally from the gut. Giving Saxenda, giving liraglutide creates a supraphysiologic level of GLP-1 agonist, receptor agonism. Acts centrally on the brain, activating our POMC system, our satiety system, making us feel more full. It also delays gastric emptying, increases insulin production, may in fact promote islet cell regeneration, decreases gluconeogenesis, and has a level of direct activity on the brown adipocytes, or level of increasing thermogenesis in the brown adipocytes. It was assessed in a series of 4 trials, the scale trials for obesity. I'm going to talk about 2 of them in a little bit of detail, the scale obesity and prediabetes and the scale maintenance trials. But across all trials, we see 5.5% to 8% weight loss, well within that magic number. Looking at the scale obesity and prediabetes trial, it included patients with a BMI of over 30 or over 27 with dyslipidemia and hypertension. All patients got advice on lifestyle, increasing activity to 150 minutes, decreasing energy intake 500 calories below their individualized energy requirements based on WHO tables, and macronutrient distribution was 30% fat, 20% protein, 50% carbohydrates. So just a standard eating plan, nothing special, decrease your calories, move more, liraglutide or placebo. And we see significant weight loss. I like to look at it from the categories of weight loss perspective. So 60% of patients lost more than 5% body weight versus 27%. 33% lost more than 10% of their body weight. Nearly 15% lost 15% of their body weight. That's what we see. About 2/3 of people respond to this medication. That 5% weight loss is considered a response. We see improvement in blood pressure, improvement in VLDL and triglycerides, no big change in LDL, decrease in CRP, improvement in functional scores, including mental health scores. Granted, they may not be clinically relevant scores, but certainly a statistically significant trend in the right direction, in addition to everything else that we're seeing is meaningful. Adverse reactions. That's what everybody wants to know about. All my patients want to know about. Nausea, of course, being the most significant, most common adverse reaction. Some diarrhea, constipation, also common. The nausea resolves with time for most people. So getting them through that 8 weeks, getting them through that dose titration, that's the key period. You have to warn people about the nausea. You have to tell people. You have to build strategies for how to deal with that. And then most people are able to tolerate it beyond that. People ask me, is nausea how it works? It's not its mechanism of action. They're not just not hungry because they're nauseous, because it continues even as the nausea resolves. Even patients without nausea have a good response in the weight loss. And I tell them, no, that's our old medications, our Orlistat and our metformin that work that way. It was followed up with 3-year data. We can see reasonable weight maintenance over that time. There was some weight regain out to 3 years. But if we just look at the general population, there's going to be weight gain over 3 years. So we still have reasonable outcome. And then the follow-up trial was also designed to look at diabetes occurrence. And in the follow-up data was only in the patients with prediabetes at enrollment, and significantly lower rates of diabetes out to 3 years, 80% reduction in diabetes. Lots of dropouts, but lots of dropouts in both groups. 3 years long trial, just injecting yourself every day. It is notable that in the they did an off-drug follow-up period. We can see there's weight regain when people come off the medication. And that's the other most common question is, do I have to be on this medication the rest of my life? And my answer to that is, you don't sign any contract with me today. You can come off the medication anytime you want. we expect to see weight regain when you come off the medication. Whether that's full weight regain, I can't tell you, but you've had how long with that lower weight on your joints, more mobility, lower risk of diabetes for those years, and that to me is a meaningful outcome. This isn't something that I would recommend for people who only want something for a couple of months. That said, we know that the yo-yo effect of the yo-yo dieting has its own physiologic problems, but people can stay on it as long as they want. People don't want to come off of it. People are upset when their insurance lapses and they have to come off of it. It changes their life. They're able to be in control of their eating. They're losing weight. They're happy with it. Everybody gets reassessed at 6 months. Everybody who has not lost at least 5% of the medication, they're non-responders. There's no need to continue it. Try something different. You have other strategies. I do want to just mention also the scale maintenance trial, because I talked a little bit about weight regain being a significant problem. And in the scale maintenance study, they looked at people, they enrolled a set of people. They had everybody stick to a really strict calorie-restricted diet. Everybody who lost at least 5% of their body weight was then randomized to liraglutide or placebo. The liraglutide group lost a further 6% of their body weight. The placebo group started to trend up towards the end of the trial, but they did actually a pretty good job of maintaining that 5% body weight. And that's an important thing. As I mentioned earlier, many patients will come to me having lost 50 pounds, 100 pounds, 25 pounds, worried about weight regain. And this is one strategy we have to help prevent that weight regain. Again, we can see significant numbers lost an additional 5 or 10% of their body weight beyond that 5% during enrollment. Back to the summary. Our next medication that we have is Bupropion and Naltrexone, called Contrave. Contrave, Bupropion and Naltrexone acts on both the hypothalamus and the mesolimbic system, so it's a little bit different. The bupropion acts directly on the POMC system to stimulate satiety. We saw from earlier trials with bupropion, there was a little bit of weight loss associated when people started bupropion. It's certainly one of our more weight neutral or weight loss antidepressants, but the weight loss wasn't really maintained, and it was a pretty small amount. Part of that was theorized to be related to the mesolimbic overdrive of that. People still wanted to eat. They enjoyed eating. They were eating for emotional reasons. They were eating for pleasure, not just for hunger. So we added in some naltrexone to try to dampen that down, impact the mesolimbic reward pathway from eating. I can tell you that my patients come to me with the same response as when you start it for somebody with alcohol. They tell me they're just not that interested in eating. My most drastic was somebody who was trying to get ready for bariatric surgery. One of the barriers was that he was drinking liters of soda a day, craving sweets all the time. Started this, he no longer was interested in sweets. He just stopped drinking soda because he didn't really care for it. Similar to what I've seen in some people with alcohol use. In contrast, I have other people for whom this is a problem. They enjoyed eating. Now they miss it. They tell me, this is something missing from their life. It was such an important thing. They enjoyed it. And now they don't know what to do with themselves. And I also see that in people with alcohol abuse, with alcohol misuse. People miss the drinking, people miss the eating because it was a big part of their life. And so there we have to come up with strategies for other things to incorporate, other ways to achieve pleasure in their life. This was studied, Bupropion naltrexone was studied in the core trials, another series of 4 trials. I'm going to talk about the basic core trials and the core BMOD trial. Across the trials, again, we see about 2/3 of patients losing 50% of their body weight, or losing 5% of their body weight. About 1/3 losing 10% of the body weight. Similar outcomes with the liraglutide. We see the weight loss relatively sustained over the trial period. improvement in our triglycerides, our HDL cholesterol, improved glycemic control. Not a diabetes drug, of course, but a 0.5% drop in A1C, which is not surprising when we consider that people are losing weight, they're changing their diet, they're maybe craving less sweets. They've also been instructed on exercise, so not totally not surprising, but reassuring to see that we're not moving in the wrong direction, we're not causing other issues. It's been shown to act on people's desire to eat, their ability to control their eating, and people report that it's easier to control their eating. Naltrexone and Bupropion was also studied in a trial called CORE-BMOD. So in the original CORE trial, patients were advised on calorie-restricted diet and exercise, and there was no real follow-up on that. That was their advice: cut back your calories by 500 calories below your recommendation, get more exercise, do what you want. In CORE-BMOD, there was intensive behavioral modification. For the first, I believe, 8 weeks, they were seen weekly, then every 2 weeks, then once a month for the duration of the trial. They were advised on a much more calorie-restricted diet, as low as 1,200 calories for the lowest, for people at the lower body weight at entrance, and starting at 180 minutes of activity, and increasing that, 180 minutes a week, increasing that to double at 7 months. And we can see it worked better. Not surprisingly. Interestingly, even the placebo group met that 5%, that magic 5% in my mind, but we had better response with the patients who also received Contrave. Of course, every medication has side effects. Can't use the Naltrexone in people with chronic opioid use. We have to watch for abrupt discontinuation of alcohol while on it for seizure risk, particularly when starting the Bupropion because of the Bupropion as well. Hepatic and renal impairment for both of them are concerns. Bupropion-related uncontrolled hypertension. Contrave does, or Bupropion, Naltrexone does increase blood pressure, so the diastolic a small amount early on. As patients lose weight, that blood pressure returns back to where it was before, so we don't see a persistent increase in blood pressure, but Bupropion does increase blood pressure. We know that from antidepressant trials anyways. Watch for Bupropion-containing drugs, for MAOIs, history of seizures, bulimia, anorexia, not appropriate to use. And of course, pregnancy. Those are the medications that we have available in Canada. We have years of experience with all of those medications in the form of Victoza, in the form of Bupropion and Naltrexone we've been using for years. They work. There's no reason why we should not be using them at this point. Looking ahead, medications that are available in America that are not yet available in Canada, Locaserin and phentermine topiramate. Phentermine topiramate, the phentermine was one of the phens in fen-phen, the less dangerous of the phens. It's still technically available in Canada. Topiramate's available in Canada, of course. It's an anti-seizure medication. Good effect on weight loss. Been studied. A safe medication. Hopefully we will have that available in Canada. Locaserin, a serotonin agonist, selective serotonin agonist. We see weight loss with this as well, probably not quite as much weight loss, but I did want to make a special note of it because we did just have a cardiovascular safety trial for this. The only obesity medication with its own true cardiovascular safety trial. We have cardiovascular safety on liraglutide from Victoza trial, but they didn't go up to the higher doses. So Locaserin cardiovascular safety trial published in New England in the fall included patients with a BMI of 27 with established atherosclerotic disease or type 2 diabetes and at least one additional cardiovascular risk factor. Most had established cardiovascular disease. Primary outcome, composite outcome, secondary outcome, new diabetes. Weight loss as expected, as mentioned, probably a little less weight loss than the other studies. And cardiovascular outcomes showing safety, no difference between the two. Interestingly, no really significant difference in rates of diabetes between the trials despite the weight loss. But it wasn't a very long trial. It was 3 years, sorry, it was long. So, in summary, obesity is a chronic disease, complex underlying pathophysiology, high level of morbidity, and we need to treat it seriously. We need to take our patients seriously when they tell us that they've been struggling with this. We need to listen to our patients. We need to consider effective treatments. I didn't go into, as I mentioned at the start, I didn't go into bariatric surgery because that was covered in a little more detail recently. But that is another line of treatment for people for whom the medications aren't the right treatment. We have treatments, we have clinics across the province specialized in this. But this is something that we can all be bringing into our own practice. We have experience with all of these medications. They're reasonably safe medications, and there's no reason why we can't be doing more of this. We need to recognize weight bias in our practice. We all have weight bias. We all use language that interferes with our care of our patients. And as we were talking about yesterday, in terms of how we're treating maybe some of our colleagues, we're not always aware of how we're coming across. And so it's important to just take a step back and recognize that what we're saying, how we're saying it, makes a difference. I also want to put in a plug for the COPS course. So this is my colleague, Dr. Zentner, has put together a course and a website to help train people. It was originally designed for family physicians, but it's been extended to a lot of general internists are attending now, training people on obesity, both how to set up an obesity practice if that's what you're interested, but also medications, motivational interviewing, bariatric surgery preparation, once a month course. And there's a website, CanadaObesityPeerSupport.com. There's a little card for it over there. So anybody can sign up for that. You just need an email to sign up for it. And all of the course videos, all of the lectures that she gives will be loaded up there. Just a few of them are now. There's also a virtual library, as well as a number of resources that we can use in clinic, including how to titrate Naltrexone, how to support patients for coverage, how to talk to patients about dieting, about carbohydrates, etc. So it's a really useful resource. And then we can questions.
Is Contrave available in Canada?
Yes, it is. Absolutely. It's available in the form of Contrave. It's about $250 a month. There's a patient support program for it, taking 20% off the cost. And patients can contact in and get counseling. There's a nurse available at all times, available during business hours, to help counsel patients on weight loss. It's actually a really useful tool for those of us that might have a little bit of less experience with the medication, as well as with counseling our patients on weight loss.
Just to see if there's any distributed sites any distributed sites have any questions? So before I open it up, maybe we should change our terminology.
Mm-hmm.
We shouldn't have waiting rooms.
There is a whole series of, in terms of the weight bias, there's a whole series of, and there's actually an it's American Obesity Association letter on how to set our practices up to be to minimize weight bias. And sure, I like that one. I don't think that one's included in their list.
Yeah. What do you say to how do you handle the patient who states, I only eat 1,200 calories a day, there's got to be a cause for this?
Yeah. So that's a complex question. And when they've looked at studies, when they put everybody on a calorie-restricted diet, everybody lost weight. Nobody comes out of starvation obese. But some people are certainly more resistant to weight loss and require lower amounts of calories. That's a great chance to use a medication, to consider surgery, and to do a food log. I have all my patients in practice do a food log. I never argue with my patients, though. If that's what they tell me they're eating, that's fine. That's what you're eating. We need to find a way to cut that back more. We need to make sure that you're getting an adequate nutrition. So we need to make sure that your vegetables are there. We need to make sure that your water's there. We need to make sure that your protein's there. And then we can look we may need to just, whatever you're eating now, that's what you're eating. And we need to look at that. We need to look at cutting that back. We can look and make sure that they're not Cushing and that they're not, that they don't have Cushing's and they don't have hypothyroidism. I don't think I need to tell you that. But that's not what we're likely to find. And so in the end, it doesn't really matter because whatever they're doing is not helping them lose weight, and we need to look at other strategies, whether that's medications or bariatric surgery, to help them lose weight while maintaining a healthy intake.
So I agree. I don't think I've picked up a single Cushing's or hypothyroid being sent to me for obesity in my practice yet. Yeah. One thing similar, but I've got to tell them is whatever you're eating is more than your body requires, rather than discussing with them, are you really eating 1,200 or are you really eating 2,000 or whatever? And
exactly, and that reminds me of...
It's not an easy question.
Exactly. In my hypertension practice, I had a patient who, was had the same issue and was adamant that she wasn't eating more. And we talked about salt intake for her hypertension. She was adamant that she wasn't eating more. And she came back the next time, and I don't think that I was being aggressive or anything. I was just asking her questions, and we checked her 24-hour urinary salt excretion. And she came back the next time. And I was like, I didn't appreciate being salt shamed. Because that's how she interpreted it. That's how she felt I didn't believe her. I can tell you that I didn't go home and care about it. I wasn't worried about it. I wanted to know so we could come up with a treatment plan. I do a food log so we come up with a treatment plan. I tell people that it's for everybody. If that patient there, I would be a little cautious with how I tell them how I recommend the food diary. But I recommend it for everybody. A food diary looks at what changes we can make, looks at where you're taking in food that you might be willing to cut back. Some people come in and they're eating a bagel for breakfast and they don't really like it, but they just do it because it's there, and that's something we can address potentially. Some people don't recognize how much they're snacking, so it just gives us that ability to make those changes. And often I'll try to incorporate it in with their job. So if you have somebody in business or accountant or whatever, I'll tell them that you would never go into, you need the data before you can make any changes in your work, before you can make any changes to whatever. And that's what we need we just need some data.
I had a question about the population ethnicity of the Contrave studies. Were they majority white? Do you think there is an ethnicity question to obesity? For example, what your genetic background is and how you might respond, for example, to Contrave?
That's a good question. I believe, although I don't have the numbers for you here, but I believe that it was a majority white. Most of the obesity studies are actually mostly white women, but it was an international study. Definitely there's a genetic component. When they've looked at diet studies and tried to come out with what diet is going to work for what genetic profile or what even metabolic profile, they don't really find much of a difference. There probably is a genetic basis to who's going to respond, or there may well be a genetic basis to who's going to respond. But we don't know, and we're not really that refined in terms of the medications. And given that we only have 2 medications, we try it and we see how it works. If people are having a lot of food cravings, food thoughts, I'll choose Contrave. If people are have prediabetes, if people are more on that metabolic disease pathway, generally I'll choose liraglutide. But in the end, it's a little bit of trial and error.
Are there any trials of Wellbutrin plus Naltrexone versus Naltrexone alone?
I don't know of any. I don't know of any evidence on Naltrexone alone for weight loss. I've not actually looked into that. That's an interesting question. Yeah. Even not a head-to-head, even just in the general data.
A second unrelated question. We know that when it comes to satiety or feeling full, there's a delay between when the stomach gets full and when we recognize ourselves as feeling full, and that time frame is roughly 30 minutes. So have there been any sort of behavior modification trials of trying to slow down how quickly we eat, because certainly in North American culture, we eat very, very fast.
That's a common recommendation, is slow down how you're eating. Don't eat in front of the TV so that you can eat slower. Don't eat at your desk. Pay attention. Be mindful of your eating. That was incorporated into the Canadian Food Guide. Is be mindful of your eating. When we're talking about patients with significant obesity, I'm not sure that that's going to be the treatment point. Just like any other dietary modification, that's likely to be an important part of it and may contribute to prevention. And certainly on a public health scale of how we can look at ways to kind of prevent obesity, that may be an important piece. But I'm not sure of any studies that look specifically at that question.
Any other comments or questions? This is a comment or a question amongst the two pathophysiologies. I mean, how do people? Are they a mixture? Does you have one? Do you identify the phenotype of what one person's going to do versus another?
Yeah, sure. So the question was about the pathophysiology of obesity, and can we identify what's driving somebody's obesity, and use that to maybe direct treatment. And we can try with our clinical history. Certainly, some of the mesolimbic system questions, the emotional eating questions, the food craving questions are questions that I ask that help direct my clinical practice. And we don't have any tests that we do for this, to kind of any lab tests or anything like that we do for it. In reality, it's a mix of everything for most of our patients. There's 30 plus hormones that are regulating our weight and our response to food, and where we can find one or two that are abnormal, we can treat them directly with the low leptin levels, the hypothyroidism and Cushing. We can treat those directly, but there's no one answer for most people, or at least we're not at that level of sophistication yet.
And the follow-up question: in our addiction population, we don't usually see obesity.
Mm-hmm.
How do you respond to that?
Sure. So there's a few. But So in our obesity or in our addictions population, we don't necessarily see a lot of patients with obesity as well. And so first of all, some of our drugs of abuse are anorexic. So our people with stimulant use, that's an anorexic drug, and we can recall a time when stimulants were used for weight loss. And certainly some of our patients with alcohol use disorder do also have obesity. So we can separate that group out. And then the opioid use that we see at St. Paul's Hospital a lot of, I'm not sure that I have a strong answer for that. I think that the population that we see here, there's a lot of food insecurity, a lot of access to food issues, and not focus on eating. But when we look at people in a higher functional status with maybe prescription opioids use, I'm not sure that we would see the same decreased rate of obesity. And when I think about patients who have come in with prescription opioid overdoses, I'm not sure that I would say the same thing, but I don't know that I have the data to back that up.
Any other comments or questions? If not, before I thank Dr. Bittman, next week's grand rounds are on polymyositis. Does it exist? Thanks, Dr. Bittman.
Thanks, Jesse. Thank you for coming.
Naltrexone is on pharmacare, but only under a collaborative. prescribing only for alcohol withdrawal for taking so it would be considered off
There's
label.
Thank you so much. That was great.
It would be
8 or 9 milligrams
so
per
it's
tab,
happening.
but you take 4 tabs a day, so it works for 36 milligrams. It's 9.
Or for 50
Oh,
milligrams a
okay.
day.
So it's still less than the 50
It's
they're
less
using
than the
for
50.
alcohol.
So if I were to use Bupropion and Naltrexone separately off the label, which I certainly do,
Yeah, only one
I would use
It's the
a
same
quarter
dilemma
tab,
as like
and I go up
people
to
with
50.
addiction to
You could,
alcohol or
I
Just
tobacco
your 50
because
then.
yeah, like I
you
started,
said, well,
I do
can't
the
afford
same with you
medication,
do
but
dose
you're spending
titration
just
of
much
1
money
tab
on
for 2 weeks,
tobacco a
2,
day or
3,
alcohol
4,
a day
2 easy, the 1's too easy. So I do that same with a quarter tab, and then a quarter tab twice a day.
They don't
Can you remind me? 50 milligrams, and then I people with side effects.
a lot of like
go
the
down
dose,
but
price them would be like
there's no
So you don't necessarily
you'll get patients who say I can't
yeah, the benefit in clinic is they're at 36, and that's really goes that way to not allow it to as easily use it off.
Oh yeah, I guess so. Yeah, that makes sense.
But we do it. They were just talking about Naltrexone. It's not
just like in addictions, there's pharmacologic treatment and there's non-pharmacologic. And you need to, and to be honest with you, at least in addiction, the pharmacologic treatment is maybe like 25%. The rest of it is actually non-pharmacologic.
But
Absolutely.
Yeah.
Well, and they kind of all do.
Yeah.
What about that? I was just going to ask you about Saxenda. Is it forever?
So yes, whatever you do to lose weight is what you have to do to
continue
keep
forever.
the weight off. So it is a long-term medication that people there's no withdrawal, there's no issue with coming off of it. So if people first want to come on, they can. Is what I tell them.
And so, what about the risks of thyroid cancer and pancreatitis? Then, how do you feel about that?
So thyroid cancer was in rats that have much more of the type of thyroid cells that cause cancer. T cells.
I see.
Yes.
So it was a rat study.
It was a rat study, not been shown in human studies, in long-term monitoring data of increased risk, and don't have much of the same thyroid cells. And then, and there's no monitoring for example. So people with history of family thyroid cancer, personal history of thyroid cancer, history of MEN or suggestive of MEN, we don't should pancreatitis, I don't know there.
Yeah.
Probably isn't.
Yeah, I just remember seeing a woman with lots of Saxenda who had pancreatitis, and I wasn't sure if she should go back on it or not.
If somebody has pancreatitis on Saxenda, I would stop it, not put them back on it.
Not.
If somebody has pancreatitis and now wants Saxenda, I would not put them on it. If they had a really clear reason why they had pancreatitis, I should say, if they had a clear reason why they had pancreatitis while they were on Saxenda, then whatever. People will get people will get gallstones with weight loss. Gallstones causing pancreatitis, so if that's their pathophysiology, sure they can.
Okay.
If it's an NYE pancreatitis we don't have a good answer for, then I would.
Yeah.
Thank you. Was it in the call room, Karen?
It was under.
I'm surprised there aren't any Naltrexone alone studies.
If you drop
There could be. I didn't detect it.
I think it's like 5 pages.
Do you know of evidence on Naltrexone and weight loss?
No, I have looked at it.
Yeah.
All right. I'm sorry. Yeah.
Because then the question is, how much
Just people coming in
additional benefit are you getting from the Naltrexone?
Yeah. I think that you do, like, pathophysiologically, it makes sense that you need that both would be benefit because the naltrexone doesn't really act on the hypothalamus, it doesn't really act on the POMC pathway in our kind of physiologic hunger.
Right.
It acts more on the reward pathway of eating.
Right.
So for some people,
But the application would be if you're unable to tolerate the Wellbutrin, is it worth remaining on the naltrexone by itself?
Yeah.
Because you can certainly prescribe that as a separate entity.
Yeah. I don't have that many people that can't tolerate Wellbutrin. Not that many people with seizure disorders out there who are that desperate and then do. But yeah, that's a good question. Thank you.
I'm sorry because I talked to the officials on the one hand, and talked to chief president.
You know Dr. Shigani? Well, I'll talk with him. Maybe you can talk with him. Okay?
Maybe he said you're going to the department. I'm going to take the chemical the talking tips and I'm looking at what's needed for IMG program. I'm a little developer program.
Okay, good enough.
Not a little.
Yeah.
I'm very happy to getting observership in the possible.
But yes, I understand. But in any case, if you could just let the department.
Yeah. Thank you very much.
Where is he? Oh. Hi. Sorry. How much you want me to start? Yeah. Sorry to make you wait. Oh. Thank you. Yeah, you can leave it. Yeah. You want to start anything or? Yeah, I can start it all up. Oh. John.
With Stacy.
Oh, okay. Sorry about that.
No. It's you're definitely not the person.
Plus, I can't recognize you guys, so I'm only one of your straps on. With regular people, yes.
using, so we're running. Ooh, you're early.
John. Anybody knows anything about Gian? We can email somebody. Dan is presenting and he did PowerPoints, and he wanted from me to use his PowerPoints. He's going to present over phone, but he wanted me to look through the PowerPoint. No, nobody needs to do a PowerPoint. I think he just did it because he had some chance or anything, but nobody needs to do PowerPoints. At least that's what I told everybody. Let me see if he emailed me. Yeah, a new device signed in. Not yet. He didn't email me. Did he email me in my wrong email?
Did you register?
No, we can't. And we need our schedule for the 5th year. Because we already registered for the POS, so they don't need us to re-register, but they want us to send an email with our schedules. So we can't until they send us our schedules. Oh, is it? So yeah, but if you're certificate in visa anything, but it's mandatory only for BDY1, BDY5, BDY4.
Number 5 is
From what?
more education.
Half of the complaints came from them. Or half of the meetings with Dr. Warburton were from them.
It's not even like it's sort of a lunch, not really.
Yeah, it's like.
No, but there is something like fish and chicken.
Well, yeah, it's kind of like picking, like cold picking stuff.
Yeah,
oh, yeah,
it's like the carbs kind of food. And they come like.
Well, but at least the carbs thing, you got like.
Yeah.
But there's no.
Too fancy.
But there's no alcohol, right?
You don't like fat in a lot of stuff, so, like a lot.
It's called being realistic.
Maybe if that didn't work.
Yeah. You know what they make us.
Oh yeah, I'm gonna check the online thing. Well, video conference. Like, who's actually checking? When do they actually look at it? I don't know.
Yeah, I would.
If I do it now, is it too late?
If someone could like sign in, it's like an attendance.
Sign in is a bullshit. Like, who wants to attend should attend. Who shouldn't attend. But people should attend. So, but they shouldn't like. Oh, you didn't attend.
No, I've never made it like that, but then it was very poor attendance or something.
Yes,
so
because one of the years there was only one person attending there.
Yeah, you know what? This goes back to the whole related with appendicitis for billing. So you get paid more for perforated appendicitis than non-perforated. So in DC, the rate of perforated appendicitis by the billing codes was like 75%. So now you have to submit a pathology report when you claim ruptured appendicitis, and the pathology report has to corroborate ruptured appendicitis.
But then wouldn't the surgeon just crush it with his grasper and make it up perforated?
Wow,
Still do that,
but it kind of like it's to the point of you can't just like do it at me and be like, oh, it was perforated and built for it.
Yeah.
Because
like
you don't have the kind of integrity that people expect us to.
Because I remember, I remember someone told me, like, in theory, if we build for perforated appendicitis, like, all of them almost will have, like, a micro perforation, so we're, like, not lying. Well.
Now that part has to say it. Otherwise, you don't get paid for it. It's just like the PMI code. So anesthesia just got a billing code for elevated BMI.
Oh, they
More
got
than
finally?
35.
But you have to submit the BMI to 1 decimal place. The surgeon has to build a BMI code. The BMI stated has to match with the anesthesia.
Yeah, that's why now you
Everybody
see
has to
at the end
anesthesia.
of procedure, like the surgeon and the anesthetist talk about this, and they document the same exact numbers so they don't get faulted.
We admitted yesterday a patient with emphysema. His BMI is 45.6.
43?
What did you guys do?
What did you do? How did you?
They just took
Hello, Jen!
What? I video conference all
Hello,
the time.
are you here?
I video conference all the time.
Don't tell Jen these kind of stuff. Come on.
Did you? What? Are we supposed to be sending PowerPoint?
No.
I'm gonna go back.
It's okay.
Okay. So I can just open it up there.
So what did you guys do? Is she okay? Was she okay?
She's just fat.
Just
Hey, don't sit like Margot back. I feel like
too low.
it's too hard.
Oh, I thought I'm sorry.
Don't they call too low, Jen?
Huh?
No, sometimes it's too low. Like you
It's
need
hard
to.
to see
Yeah,
that.
it's harder to see.
And I have a appointment at 4, so I gotta leave. It's recording. Okay, fine.
Alright. So you have to leave at what time?
So I can go first.
There's another person who wanted to go first also.
Oh, who was that?
Dan. He had also a doctor appointment at 4.
Oh, he can go first.
Either
Because
one.
mine's like near downtown.
CG Mobile. What's this? BH Boardroom.
Announcement.
Can you close that button, please?
Did I press? I didn't. I didn't go there.
Go.
Just looking.
How's MTH?
Pretty good.
Your call will be disconnected.